and mindfulness-based stress reduction. Her research focuses on the delivery and study of complementary health interventions with traumatized populations. Over the course of her career, her research has evolved from a primary focus on community-based trauma exposure to a complementary emphasis on clinical behavioral interventions for PTSD. That approach has led to multiple multidisciplinary collaborations with expert clinical intervention researchers and community-based organizations, contributing to a better understanding of how to address gaps in mental health treatment engagement in a population that is underserved and overexposed to trauma, and who experience significant PTSD symptomology. This is critical for improving the public health impact of trauma interventions. Thank you very much.
Thanks, Ben. Good morning.
Good morning.
It's my birthday today. Thank you for coming to my party. Because it's my party, we're going to talk about my favorite things, mindfulness and PTSD. My daughter asked, my 3-year-old asked if she could come to my party. I was like, you don't want to come. I want to acknowledge my mentors, Kathy Hefner, Will Pigeon, Kate Cerulli. Work closely with mindfulness teachers, Mick Krasner and Trish Luck. I received funding and a lot of resources from my CTSI. I've done a lot of work through Center for Community Health, and as well as HEAL, and developed partnerships with, over the years, with St. Joseph's Neighborhood Center, Willow Domestic Violence Center, Monroe County Family Court, and resolved some community-based domestic violence centers. So today I'll review post-traumatic stress disorder. I'll talk about the rationale for why we would use mindfulness-based interventions to address the symptoms of the disorder. I'll talk specifically about the theoretical basis and how that informs proposed pathways and mechanisms for mindfulness interventions. And then we'll look at some of the outcomes of mindfulness-based randomized control trials. I'll talk about the work that I've done and where I'm going with it. So exposure to actual or threatened death, serious injury, or sexual violence is pervasive, it's widespread. Worldwide, 70% of adults will have been exposed to a traumatic event in their lifetime. Worldwide, 30% of adults will have been exposed to up to 4 traumatic events in their lifetime. In the US, 6.8% of adults meet diagnostic criteria for post-traumatic stress disorder. So this is a pervasive disorder, and PTSD is the most common psychopathological consequence of exposure to a traumatic event. So not everyone who experiences or exposed to a traumatic event develops the symptoms. But we know that in the US, for example, interpersonal violence is the most frequently reported traumatic event, and the individuals exposed to interpersonal violence are actually at the highest risk of developing post-traumatic stress disorder. So for example, the respective probability for men who've experienced rape is 65% and 46% for women, and 2% and 22% after physical assault. So interpersonal violence is defined as any type of violence between family members, intimate partners. It can also happen in the community from acquaintances or strangers, and that can include physical or sexual assault. So what does post-traumatic stress disorder look like? The core features of the disorder include the persistence of intense, distressing, and fearfully avoided reactions to reminders of the triggering event. So people work really hard to avoid those intense and distressing memories, emotions that are associated with the traumatic event. We also see alterations in cognition and mood. So that would be negative beliefs about yourself, shame narratives, distorted beliefs about the cause of the event. So a typical thought process for somebody with post-traumatic stress disorder will say, I shouldn't have gone there that night, I shouldn't have left that night, things like that. So there'll be this distortion of the cause of why they experienced a traumatic event. We also see anhedonia. There's also a pervasive sense of imminent threat. We also see disturbed sleep and hypervigilance. So the American Psychological Association classifies those psychological symptoms as intrusion. Those are the memories, the dreams, nightmares, the avoidance behaviors, numbing, avoiding memories and people, the negative cognitions and mood. So those alterations that look like depression, and then the arousal symptoms. And underpinning these clinical symptoms are changes in the ability to self-regulate. So this includes regulation of cognitive control, the ability to plan and engage in goal-oriented behavior. Emotion regulation, the ability to modulate your experience and expression of emotion. And then physiological stress regulation, the experience of arousal in your body, responding to a memory and emotion. So what's driving these changes? A lot of things. The neural systems that are thought to have a prominent role in the pathophysiology of PTSD primarily include the amygdala. So what we see is abnormal fear learning. And so people with post-traumatic symptoms and post-traumatic stress disorder, because of avoidance patterns, don't engage in safety learning and fear extinction. And so interventions like prolonged exposure is based on the concept of abnormal fear learning. We also see exaggerated threat detection. So that's the hypervigilance and a preferential attention to threat-related stimuli. One that's quite interesting for me is the changes in executive functioning, because emotion regulation relies on the integrity of executive functioning. And so this is rooted in the prefrontal cortex. You see impaired regulation of emotions, which often manifests itself in irritability, anger, reckless behavior. And you also see effects on attention, inhibition, the ability to switch tasks, plan, make goals, concentrate. And finally, contextual processing. This has emerged as one of the more important aspects of neural changes in post-traumatic stress disorder. That people with the disorder don't know how to properly respond to stimuli in the environment. So that it can be characterized as the hypervigilance, but also that inappropriate and misread of their safety in the environment. So a description or often used is seeing a lion. I don't know why a lion would be in your backyard, but seeing a lion in your backyard and then seeing a lion in the zoo. It changes how you respond. The context is important. But for someone with post-traumatic stress disorder, those cues are weakened, and therefore they might feel threatened despite safety. So you can imagine that a distorted alarm system, perceiving danger everywhere, and difficulty with contextual processing, being able to discern whether you're safe or not, interferes with the ability to regulate feeling, regulate thoughts, make plans, regulate your physiological stress responses and reactions. And so often what we see is these post-trauma reactions that are quite typical for anyone who's experienced a traumatic event, and what's understood as a way that it essentially turns into a disorder is the avoidance patterns, the escape patterns, because you can imagine that being the intensity of that fear would make a person want to engage in behaviors that are distracting or numbing. And avoidance behaviors are considered the cornerstone of post-traumatic reactions that lead to the development of PTSD. So how is this treated? The first line treatments are considered trauma-focused interventions. So your gold standard are cognitive processing therapy, prolonged exposure. They're based on cognitive models. So they're really looking at trauma-related beliefs, memories, and emotions. Cognitive processing therapy, for example, will work to have a patient accept the reality of the event, feel the emotions associated with the event, and then work to change what they would call the distorted beliefs about the event that would often focus on what the person, the narrative that the person tells themselves about the cause of the event, and then changes that have happened in terms of their own understanding of themselves, others, the world around them. It focuses on safety, control, and power, esteem, intimacy. So trauma-focused interventions are considered first line, and we see large effect sizes. But we also see a problem. The dropout rates are 50 to 60%. They're ineffective for as high as 50% of patients. And both patients and providers are asking for additional options. So this is where my interests come in considering what non-trauma focused interventions would look like. This is harmonica-based stress reduction. I just love that that exists in the world. And if you ever need a laugh, just go to YouTube. And I mean, why not do movement and make music at the same time? It was genius. Okay, that's not what I do, but I do enjoy it. Okay, I'll move on. So mindfulness has gained a lot of traction in the last couple decades. People are really interested in it for a whole host of disorders, for anxiety, depression, and more recently has started to study its effects with post-traumatic stress disorder. So we see a lot of work with combat veterans. The VA is interested in mindfulness as what's called a non-trauma focused intervention. So what is mindfulness exactly? It's popular. I'm sure most of you have heard of it, have practiced. To go into its basic premise, it really starts out as a systematic training of your attention and your awareness at its most basic. And out of Berkeley, they'll call that M1. They have this grading scale that M1 through M4, and M1 is just at its most basic core concept is really training your attention and your awareness. But as you go up in the M's, if you will, in the levels of the type of mindfulness that you practice, when you get to M4 level, if you will, that's talking about the type of awareness and acceptance required to engage in a mindfulness experience. So that would be the non-judgmental acceptance that is rooted really in compassion work. So how does one experience the present moment with non-judgmental acceptance? you first, in first training attention and awareness, what you do is you do a lot of practice. There's a lot of formal practices. So it's often in a group-based setting. Mindfulness-based stress reduction, for example, is a 8-week manualized treatment. People will come in a group setting. They'll practice for 2 hours. There's 4 formal practices. There's the awareness of breath meditation. There's hatha yoga, walking meditations, and then a body scan in which you scan the body from your feet all the way up to your head. I always find the body scan fascinating work to do with trauma population, because you are working with the non-judgmental acceptance of a place where violence occurred. And so that shift in experiencing your body as a source of peace, as a source of strength, is quite a shift. So the practice first has you start out with focusing your attention just on breathing. And if any of you have ever practiced, you know how hard that is to focus your attention on just your breath. Right? We might focus our attention for a few moments on just breathing and then go into some future moment or rehash some past moment or what's on my phone or can't believe she said that or whatever. And then we come back to the breath. And so this systematic training is really a practice of helping a person redirect their attention back to that focus. And so we start with the breath. In mindfulness language, the breath is always with us, right? So we can always use it as a point of focus. There's also a type of attention training and open monitoring in which you are paying attention to your internal experience, your emotions, your thoughts, your physical sensations, and then the environment around you with an openness, not needing to change any of it. So that the idea there is that that's countering stress reactivity, because there is no fight, there is no flight or avoidance. You're simply noticing the experience of life as it unfolds, to speak in mindful language again. So as I said before, if you've ever practiced this, you know how difficult it can be, and that it really does require a lot of practice. So we have our formal practices where we engage in both the practices themselves in a group setting, and then there's a lot of inquiry. What did you notice? What's the story you're telling yourself about your body, your sensations in this moment? How do you describe your emotions? What do you call pain? Can we be more specific? Can we call it a tension or a heat, for example? And then people also practice outside of the home and have home-based practice, their home-based practice as well. So when you're practicing, you know how easy it is for your own brain to jump from one thing to the next. And so you can imagine that somebody with a post-traumatic stress disorder, that this is quite difficult to do. And so I often consider just what I'm asking people. I'm not asking people, it's called stress reduction, but it's really important that that's communicated clearly, that initially, especially, this doesn't feel like stress reduction. It hurts. It hurts to pay attention to your present experience, especially if your present experience is riddled with physical pain, emotional pain. You don't want to notice it. Why would you want to stay with it? And so that's the invitation of mindfulness practice, is to see if people can start to exercise that ability to stay connected with their present experience. and see if it's possible to not have to distract or numb, engage in avoidance behaviors. I wanted to just quickly go over some what are called the attitudinal foundations of mindfulness. These are considered all of the attitudes that essentially come from or come out of mindfulness practice. So one is that non-judgment. So it's the practice of simply noticing something for just what it is, not needing to change it, to evaluate it as good, bad, right, wrong. I want more of this, I want less of this. And so again, that first part of the training is just simply noticing your internal landscape, if you will, noticing that tendency to engage in that judging language, especially of the self, that critical language. And notice that that's actually quite different from cognitive models that are having you grab the thought, label it, and then label it as distorted in some way, and then change it. Mindfulness is quite different in that way, in that it will have you notice a thought, for example, and then let it go on by. There's visual exercises where you can imagine putting the thought on a leaf and letting it go down a stream. Imagine putting that thought in a bubble and letting it float away, or watching it go by on a cloud. Meaning that you're not really working with the thoughts specifically. You're just recognizing that thoughts come and go. Sensations come and go. Emotions, painful emotions come and go. And can you stay connected with your own experience as they come and go? Again, rather than needing to engage in avoidance or numbing behaviors. So that requires patience in your practice. What we call a beginner's mind, being able to see yourself, your experience as if for the first time. Trusting that your practice will essentially, sometimes I don't know how to use non-mindfulness language, unfold over time. Non-striving is the attitude in which you practice essentially not trying to push for any goal. And people often get really stuck here. Is it bad to create goals? It's not necessarily bad to create goals, but the question is, how do you relate to those goals? And is it possible to have flexibility and not need to force something to happen in a particular way? Acceptance and letting go is a big part of mindfulness. Accepting just what is your own experience. Doesn't mean you have to like it necessarily, but we often have to start with just seeing reality for just what it is. And then noticing what holding on to something, holding on to an expectation feels like, and then seeing if you can, if possible, let it go. The gratitude is also an attitude, didn't mean to rhyme, but it is part of engaging in practicing being grateful for your experience, no matter what it is, having compassion, being with your own self in suffering. So language I often use as a teacher is, can you look your own pain in the eye? Can you look yourself in the eye in your own experience and stay with it, not needing to turn away? When it comes to mindfulness-based interventions specifically for post-traumatic stress disorder, there's 3 different components that make up the theoretical basis of why it's effective for mindfulness-based interventions. So first is, as we discussed, training sustained and purposeful attention. So that's specific to post-traumatic stress disorder, that's attention to the present and away from attentional bias toward trauma-related stimuli. So the practice of continually bringing your attention back to just where you are rather than a future or past orientation. Mindful cognitive style, that is a label for simply engaging with the contents of consciousness, your thought life, in a mindful way. That's the non-judgment, the acceptance. And the idea is there that with those attitudes, you can reduce rumination. You can reduce, rumination is an emotion regulation strategy often used in post-traumatic stress disorder that's really ineffective, trying to go over and rehash the event that or any difficult or stressful moment. And so by practicing things like acceptance, non-judgment, we see reductions in rumination. And then finally, that non-judgmental acceptance, allowing you to approach difficult situations rather than avoid them, reduces emotional numbing and reduces thought suppression. In terms of mechanisms, we can look specifically at PTSD symptom clusters and then the hypothesized mechanisms that are associated with it. So for the intrusion symptoms, the memories, dreams associated with a traumatic event, one hypothesized mechanism would be shifting attention to the present and reducing that attentional bias towards trauma-related stimuli. For avoidance, increasing your openness to experience, your willingness to approach fearful stimuli. So there has been evidence that reduced avoidance behaviors have followed a mindfulness-based intervention. The alterations in cognition and mood is hypothesized to be driven by the non-judgmental acceptance of trauma-related cognitions. So there has been evidence that increase in self-compassion drives changes in post-traumatic stress symptoms, reduced self-blame, for example, in mindfulness-based cognitive therapy, which is specifically for depression. And then the alterations in arousal and reactivity reduced attentional bias toward trauma stimuli and increasing the ability to remain present. We've seen evidence that non-reactivity and acting with awareness is associated with reduced hyperarousal. David Creswell out of Carnegie Mellon has looked at mechanisms associated with changes seen in high-stress populations. So this includes any improvements in stress-related disease outcomes. So looking at people with psoriasis, chronic pain, and post-traumatic stress included. The idea being that mindfulness intervention in increasing attention and monitoring skills, as well as acceptance skills, increases the stress resilience pathways. So these neural changes essentially are altering stress appraisal and then decreasing physiological stress reactivity in the sympathetic nervous system. So you see increases in regulatory pathways associated with prefrontal cortical activity, decreases in amygdala activity, and which then in turn are related, again, if emotion regulation relies on the integrity of prefrontal cortical activity, improves emotion regulation, decreasing the distress, the tendency toward rumination, which is again common in post-traumatic stress disorder. And together, the physiological stress responding decreases sympathetic nervous system reactivity and HPA axis reactivity. Mindfulness-based interventions in terms of outcomes for anxiety, depression has seen moderate effects. So at this point, it's considered second line or complementary. We've Evidence shows that it increases regional brain gray matter associated with learning, memory, and executive decision making. There's also been evidence of decreased amygdala activity and improved immune function. So we wanted to know what effect sizes were looking like for post-traumatic stress disorder. So we conducted a meta-analysis of meditation and yoga for post-traumatic stress disorder. So we looked at 29 studies of both mindfulness meditation, different types of meditation, like transcendental meditation, for example, and trauma-informed yoga that were randomized control trials. And I highlight the 9 randomized control trials of mindfulness-based interventions for PTSD, and the effect size was in the small to moderate range. Those studies, those randomized control trials, saw significant decreases in post-traumatic stress symptoms, including intrusion, avoidance, and arousal, and improvements in mood. So this is, again, gaining a lot of interest. It allows for a complementary approach. It allows for a different option for patients. We also see lower dropout rates with non-trauma related interventions. Some of the weaknesses that are often associated with mindfulness-based interventions are methodological in nature. There's variation in dose and duration, for example. So there's a lot of, it's becoming really important to the field to really standardize and systematize the way that the mindfulness-based interventions are delivered. This is a forest plot of the mindfulness-based interventions, as well as the other meditation-based approaches and the yoga-based approaches. So they were all falling in the small to moderate range of effectiveness. So in terms of my own work, something that's been really important is being able to offer this intervention to people who are highly exposed to trauma and under-resourced. When I was a postdoc, I conducted a non-randomized trial. It was a community-based effort. I worked closely with St. Joseph's Neighborhood Center, and I was embedded in the organization at the time. And I recruited 50 women who had exposure to interpersonal violence across the lifespan. A requirement at the time was not to have post-traumatic stress disorder, but I was interested in high levels of perceived stress. So this was a low-income population. If you know St. Joseph's Neighborhood Center, they serve a low-income population. So in this pilot study, I saw significant decreases in post-traumatic stress symptoms, significant decreases in emotion dysregulation, perceived stress, depression, trait and state anxiety. I also saw increases in non-judgment associated with mindfulness. We also looked at inflammatory biomarker IL-6 and saw that greater attendance was associated with decreased post-treatment from inflammatory biomarker IL-6. I then received KL2, and I looked at the effects of mindfulness specifically on post-traumatic stress disorder. This again was a community-based clinical trial, and I was looking at survivors of intimate partner violence. So I was recruiting out of Monroe Family County Family Court, and Willow Domestic Violence Center. I also recruited here out of HEAL and the Women's Health Clinic. So the idea was to develop a proof of concept study to look at a psychophysiological model of mindfulness-based stress reduction, given that existing PTSD interventions aren't fully informed by psychophysiological models of stress. They're often ineffective for many PTSD patients. Being a community-based model meant that I had a community advisory board. I worked closely with the domestic violence organizations, really to address gaps in mental health engagement in a population that is underserved and overexposed to trauma. So the aim was, the first aim was an acceptability, feasibility aim, and then the second was to test the model. I recruited 29 women and randomized them to receive mindfulness or a wellness control. I just have done some preliminary analysis, and I just want to show you that there is significant decreases, for example, in post-traumatic stress disorder over time, and that orange line is indicating where we would see a clinical cutoff for post-traumatic stress disorder, so the blue being the mindfulness group. And a similar decrease for, a significant decrease for difficulties in emotion regulation. So that would indicate that a higher or improved ability to regulate emotion in this population. So at this point, I've become interested in wanting to understand how to improve mindfulness, make it more effective for this population. I think we're seeing, as you've seen, we're seeing some small to moderate effect. And so the question is it, whereas we see somewhat larger effect for things like anxiety and depression. So is it possible to augment mindfulness? So the idea is that I would augment mindfulness-based stress reduction with a computerized cognitive training. The rationale being that, first of all, non-trauma focused interventions have to target these critical mechanisms that perpetuate PTSD symptoms, and that cognitive control is diminished in post-traumatic stress disorder. So these deficits in cognitive control lead to difficulties in adaptive, cognitive-based emotion regulation strategies. So the idea is that strengthening cognitive control through cognitive training and computerized cognitive training prior to engaging in mindfulness would improve the effects on outcomes. So the central hypothesis being that augmenting mindfulness with cognitive training would lead to efficacious improvement in cognitive control, and in turn, better emotion and physiological stress regulation and concomitant PTSD symptom severity. This study would look, I would expand from looking primarily or exclusively at women. I would like to include both men and women. I would continue my relationships with community-based organizations, and I also have now connected with the Greater Rochester Practice-Based Research Network as well. And this would also focus not just on intimate partner violence, but on interpersonal violence. I wanted to close with participant feedback that I've received over the years through evaluations. This is some of the most, well, it's the reason I do this work, and it's very meaningful to me. Someone with post-traumatic stress disorder and also chronic pain described the ability to learn to relax into her pain. I just thought that was such a powerful way to describe using mindfulness to be able to accept and experience pain, so much so that her body could actually relax and not engage in stress reactivity associated with pain in her body. Another powerful statement: I thank my body for reacting when I needed it to react. I remind my body that I do not need it to protect me from danger in this moment. So anytime she would experience some type of stress reactivity, she would recognize it with gratitude rather than fear, or compounding the stress reactivity with engaging in stress-related thoughts and fear. She would instead recognize, take into context that she was safe. My body is a source of peace for me, when before it was a source of so much pain and fear. The power of a non-trauma focused and complementary intervention like mindfulness is that it really does not only work with cognition regulation and emotion regulation, but is also really working with the body and working to use the body as that source of peace or source of strength, focusing on your breath, focusing, for example, with the body scan, and not needing your body to feel any other way than it does. So is it possible for your body to actually be that source of strength or source of peace? And my favorite, I hate the phrase, it is what it is, but it is, isn't it? Okay, thank you. Any questions?
This is one of the most soothing grand rounds. I wonder if there's been any research on cultural, ethnic, even spiritual factors that influence people being more responsive to mindfulness. And if there's any research on refugee populations.
That question actually has come up. And so there is actually there has been some work with refugee populations. But it was a long time ago. And it was not a randomized controlled trial. But recently, I've seen a new emergence of people becoming more interested in using this with refugee populations. I can just also say that I've done some work in, oh gosh. I'm staring at myself. Hold on. Just breathe. It is what it is. I'm distracted. Refugees. That there actually has been some pushback against engaging in a spiritual practice that would be distinct or different from their own spiritual practices. So I don't know enough about it, but there is definitely a reemergence of interest there. Yeah, hi. Yeah.
I work in developmental pediatrics. They are doing mindfulness where the parents teach us the caregiver stress.
Yeah.
Mm-hmm. Well, I guess my question is there any reimbursement, like any insurance where the mindfulness approach to?
Yes. George, do you know? Yes. It's therapy, yeah. Sorry. Yeah.
One of the things that I'm very concerned about is trying to make treatment decisions when trying to be the treatment like CPC, mindfulness-based stress practice. Are there any indicators that would suggest the way?
It's a really good question, and I think about that one a lot. So I would say that in terms of considering cognitive processing therapy as a first-line treatment for post-traumatic stress disorder, and if you've really explained the rationale of cognitive processing therapy and someone is really on board and seems able to engage in the type of work of choosing a traumatic event and then being able to work through it, I would certainly encourage you to go that direction. In terms of choosing mindfulness, it's not just, I wouldn't think of it just in terms of, oh, if that doesn't work. But often you may see, for example, a veteran I worked with, a feedback she said was, I've done all the cognitive processing in the world. I know how to process these thoughts. I know how to challenge them. But if somebody's working on their roof and, using a nail gun, I'm, crouching in the corner. And so I think that it's important to think about the effectiveness of working with the body and physiological stress reactivity. So I would want to really know, and what I often want to know is what their symptoms really look like. Does that make sense? Yeah.
I have a similar question.
Okay.
In relation to patient selection.
Yeah.
Why would you choose mindfulness over CBT?
Yeah.
And vice versa?
Yeah.
What are the evidence related to comparative?
There hasn't been comparative treatments, but I will say that the reverse of not choosing mindfulness would be for someone who's experiencing a lot of dissociative symptoms. I wouldn't do mindfulness with that person.
A lot of thanks for a great presentation and real integration of science and practice that you really practiced in your career. And I'm interested in career development of folks like you who are both clinicians and researchers. So my question comes from a different kind of angle, and I'm kind of wondering, knowing that you are also a clinician, at least half-time, and you are a primary researcher and trying to launch a research career, do you feel that it's been helpful, this kind of scientist practitioner model? Or, and again, this is kind of not a fair question because it's really about career development. But is there anything you can comment on about pros and cons of really being in the trenches and developing a treatment at the same time?
Yes. It's always been so important to me as a clinical intervention researcher to continue to be engaged clinically and to be delivering interventions. It allows me to, I think, engage with my questions in a unique way and really glean a lot of information from patients themselves. I think when it becomes difficult, it's just percentages, just time.
I have time to do everything.
Yeah.
Yeah. But it's shaped the way that you developed your research?
Oh, yeah, absolutely. Yeah.
Thanks.
Yeah.
What would you say you shouldn't?
I would say that you should not use mindfulness for people who are experiencing dissociative symptoms or people who are really not able to engage in the teachings of mindfulness when it comes. Sometimes I think that mindfulness can be a little bit poetic or ethereal. So if you have someone who really wants something more concrete, really direct, something like cognitive processing therapy would be helpful. And I'm also interested, and I have not really gone into this, but I think ACT does a really good job of synthesizing mindfulness into more.
What about people who have had or have some evidence of psychosis?
I would not recommend that. Yeah. And also just for trauma-informed work with someone with mindfulness, I did want to speak to that. There is a lot of explanation around what you're engaging in, and if you do feel too distressed when you're going through a body scan, for example, just stop. Like, you don't need to push the person to engage in that meditation in that moment. And that they have a lot of that sense of control and power to choose to stop a practice if it feels too overwhelming. Oh, yeah. Thank you.
So there's actually, you mentioned ACT, which is the clinical and research interest of mine, mostly with adolescents, but also with more youth populations. And there's actually a protocol for ACT for psychotic patients.
Yeah.
It's a group protocol that we're just starting to kind of look at. I don't know how much data has been collected, and I think what's interesting to Eric's question too is that the mindfulness component is minimized in that protocol. It's there, but it's minimized for more of the kind of notice the thought and let it go versus be in it. So I think that there's an emerging body of and this is social with ACT, but there's a ton of ACT data for almost everything, but this is kind of an emerging clinical aspect of that that's coming out too. So.
Oh, interesting. Thank you.
Yeah, it sounds like a fertile ground for a grand round.
Okay. Thank you.
Thanks.